All right. Okay, we're live. Good morning. Well, it's afternoon. Good evening.
Good evening.
Depending on where or when you are watching this Facebook live. I'm Dr. Ola Vinton here again to have topics that help our patients live long and well because we believe in the quality of life and the quantity of life. They're both equally important. And I'm happy to have on the one and only Dr. Chanel Wilson.
Hello, everybody. Thank you.
Um, Thank you so much for coming. I know you're busy. This has been a long day, I bet, and you're here having discussions with our audience. So thank you so much.
Thank you for having me. Excited to be
Awesome,
here.
awesome, awesome. So our topic today is Doc. My bladder is embarrassing me. Leaks here, leaks there. Help me. Of course, we're having talks with you as a urologist. So tell me, Doc, who are you? For those who are watching, who are you and what do you do?
Yes, well, my name is Chanel Wilson, and I'm a urologist and a urogynecologist. I run a solo practice in the Atlanta metro area called Metro Atlanta Urology and Pelvic Health Center, which is in Kennesaw, Georgia. And I'm also on faculty at Morehouse School of Medicine as the urogynecologist. So I focus on sexual and voiding dysfunction in males, females, everybody in between. Just really focused on helping people achieve the quality of life that they deserve.
Awesome. I like what you do, Doc. I like what you do. Now, inquiring minds want to know. And by the way, if you're watching live, hashtag live. You're watching a replay, hashtag replay. But Doc, why do you do what you do? Is there a story behind why you chose this field?
Well, honestly, urology, it kind of encapsulated all of the things that I liked about medicine and what I wanted to do with my life. I, I was a nurse before. I was in the ER. I dealt with life and death situations all the time, very sick patients, and I have a special place in my heart for those patients. However, I always noticed that folks in medicine are so focused on having people live for like a long time, and they don't necessarily focus on the quality of that life. And my feeling is I don't want to be alive if I'm in pain and miserable and I can't enjoy my life. And so I wanted to make sure that from a medical standpoint I was focusing on that because I knew most physicians are going to focus on life and death situations. We're very, very good at treating disease. We're very good at prolonging life, but I wanted to focus on the quality of life.
I
I
like
also knew I wanted to do surgery, and so urology kind of combined those two.
I like that. Quality and quantity of life. We don't
Yeah,
want
for
people to
sure.
just endure life, but also enjoy good quality of life, even in that longevity. So very, very
Exactly.
important. All right, so let's get right into it. We're talking incontinence. So for
Yes.
someone who's watching, who's like, what is incontinence? What does that mean?
Sure. So when people talk about incontinence, usually they're speaking about urinary incontinence, and
Mhm.
so that's leakage of urine that is not intended. So incontinence can be caused by a lot of different mechanisms. So oftentimes when people are speaking with their friends or whoever about their leakage, they think that, okay, well, I'm leaking, they were leaking, the treatment that worked for them is going to work for me, but we often don't realize that there's a lot of different types of incontinence and causes for incontinence. So the main ones that I see are urge urge urinary incontinence that's
Mhm.
oftentimes coupled with overactive bladder, and then there's stress urinary incontinence, which is when we leak when we do things that increase our abdominal pressure, like coughing, sneezing, laughing, jumping, running. Um, and then some people can have a mixture of both, which we call mixed incontinence. So that's mixed urinary urge and stress incontinence. So the treatment for all of those, each of those conditions is different. And when they occur in combination, we have to look at what bothers people the most and kind of tailor the treatments to the patient so that we can achieve their goals.
Okay. Thank you for answering the question on the different types. Um, but for someone who's wanting, let's start with the urge incontinence. What causes it? Like, what are the most common causes you find? If someone's asking, like, did I do something to cause it? How
Yeah.
did somebody else not do? What would you say, Doc?
Yeah, so when patients come to see me with overactive bladder or urge incontinence, there's a few things that I screen for that I know can contribute to those symptoms. The first is their caffeine intake. Caffeine is a known bladder irritant, and even if someone has been able to tolerate it their entire lives, as we get older, as things change, as we change, we may become more sensitive to it. And so oftentimes, the people who are drinking 2, 3 cups of coffee, or like in the drive-through at Chick-fil-A, most of my patients know I'm always saying that I'm going to write a letter to Chick-fil-A and beg them to have decaf sweet tea. And so those patients tend to have a lot of overactive bladder and urge incontinence. So whenever I find patients who are using a lot of caffeine, that's one of my first recommendations. I also look for patients who have constipation. If you think of the pelvis, it's a bony bowl lined with muscles, and no matter how large we get on the outside, our pelvis and our internal space is limited. So if you're full of poop, for lack of a better term, you're not having a bowel movement every day, that means that the space that your bladder could use to expand is taken up now by a bunch of stool. So patients with constipation, they lack the amount of space to store urine, so they're much more likely to have overactive bladder, urge, and then their pelvic nerves are also trying to get them to have that bowel movement. So those same nerves are irritating the bladder, are also innervate the bladder, and so you can get a lot of cross overactive and urgency and irritation. So a lot of times you'll see urge incontinence and constipation go hand in hand.
Okay, so you mentioned caffeine. Now,
Yes.
some of you are watching like, oh, don't mess with my coffee. Soda is a good source too. So I
Yeah.
have a lot of patients who drink a lot of soda. I don't drink coffee.
Mountain Dew.
All that soda too can
Definitely.
irritate. So this is good to know as well. And I see that a lot with the constipation too. Interesting. You get it a lot with kids, like babies, infants,
Oh, yeah.
and also as adults, see the same space. All right, Doc. Let's go to stress incontinence. So what would you say are the most common reversible causes of the stress incontinence?
Sure. So stress incontinence, just at baseline, it's leaking because of increased abdominal pressure. So if you think about the things that can increase abdominal pressure, that's weight gain. People when they're pregnant, that can increase abdominal pressure. People who have a chronic cough, they can just wear out their sphincter. So things like that are pretty associated with stress incontinence. Anyone can get them. We tend to see it in women who've had vaginal deliveries. We tend to see it in men who've had operations on their prostate, so after prostate cancer surgery, or even surgery to reduce the volume of their prostate for benign disease, they can get some stress incontinence. So there's a lot of different causes, but just anything that you can think of that causes an increase in that abdominal pressure can lead to stress incontinence.
Awesome. So now let's talk about Kegel exercises.
Yes.
Because that's usually the go ahead and Kegel, you'll be good. As a urologist, I mean urogynecologist, are there, what do you say to that? Is that a general rule for incontinence issues?
Yeah, so that's a great question and one I get a lot. And Kegels, when people are usually talking about Kegels and pelvic floor muscle exercises, they're talking about contracting the muscle and causing it to just basically strengthen that muscle. Right. And so that really works more for patients who are suffering from stress incontinence, because the issue for them is that their outlet is weak. So when you try to strengthen that outlet, strengthen the sphincter, then that can help to treat stress incontinence. That won't really help urge incontinence. Now, sometimes these pelvic floor strengthening exercises can help to decrease these feelings of like urgency, but then in and of themselves, pelvic Kegel exercises isn't really indicated for urge incontinence and overactive bladder as much. And a lot of times when patients have pelvic pain, they're always having UTI-like symptoms, but without UTIs, they're having vaginal discomfort, and they have leakage because it's from urge incontinence, or maybe it's mixed, and they've been doing a lot of Kegels. What they're actually doing is causing their already spasmed and tight muscles to spasm even more, and so they can actually cause more pain, more discomfort, and worsened incontinence by doing Kegel exercises. So you really want to make sure that if you are doing those, that it's the indication is for stress incontinence, unless you've been evaluated, to make sure that doing Kegel exercises won't do anything worse. And it's not the only thing that can be done, but I always recommend non-surgical behavioral management first, because as much as I love to operate, I know I don't want to operate on anyone who doesn't need an operation and can fix themselves by by treatments that they can do themselves. So with Kegels, the way people do it, a lot of times they think that you should be urinating and stopping your urination. Please don't do that. When you're urinating, please let your bladder empty. But when you're not in that process, you want to hold in, like you're trying to hold in gas.
Okay.
That's that squeeze that you're trying to do, and you want to hold it for about 2 seconds and eventually build up to, I tell people about 5 to 7 seconds. That's how long you want that contraction to be. And you want to do 10 of them in a row. Okay. But in between each of those contractions, you want to let the muscle fully relax. So usually I tell people to take a deep diaphragmatic breath so that they're allowing their muscles to fully relax before doing that contraction. You want to do 10 of those in a row, at least 3 times a day in different positions. So the first time laying down, the second time maybe standing up, the last time sitting down, whatever a combination of those. But you want to get the muscle at those different angles by being in those different positions.
Awesome.
Yeah.
I like the analogy, the descriptive instruction. Pretend like you're trying to hold in gas. That's actually very good. And you take a breath in between, and then the different positioning. I've not heard that before. That's really good. So different ways, and that's how you make the Kegel exercises count.
Yeah, and I usually tell people to do those for 3 to 4 weeks. If you don't see any change, and you're doing them correctly, okay, then that's an indication that maybe that's not enough, and you should maybe get further evaluation for treatment.
All right, Doc. I have a random question. So someone's wondering, is it bad to hold your urine? Like for those who are like, I can't pee outside. It has to be in my house. As a urologist, would you think is that a good thing to do? Is that strengthening your Kegel muscles? What would you say to that?
Yeah, to that I say don't hold your urine if you can help it. Obviously there are situations every once in a while, but it should be more of the exception than the rule. In general, I tell people they should be urinating every 3 to 4 hours while awake at minimum. If I listen to them and they're only using the bathroom 2 to 3 times a day, I'm like, okay, I need you to go every 2 to 3 hours during the day so I can get you into the habit of going when you feel that urge. And so the reason that's not really going to help your sphincter, because remember, we don't do Kegel exercises in the verge of when we're trying to urinate. You want to be otherwise relaxed and just focusing in on those pelvic muscles. But what you can be doing is you're stressing out your bladder. The bladder is stretchy, but if you continue, think about it like a rubber band. If we stretch a rubber band if we stretch it too much, then it loses a lot of that elasticity. And that means that in the bladder can result in decreased bladder strength, and that can eventually cause a lot of voiding dysfunction and issues down the road. So you can actually be causing irreversible damage to your bladder if you're in the habit of holding it all the time. And in worst case scenarios, and I have seen it, I've seen patients who've gone into retention and not been able to recoup their bladder function because truck drivers are the worst ones, unfortunately, who are just driving through the night and not urinating. And I've seen people go into retention from that.
Okay. And just to give perspective, if you have retention issues, it could affect your kidneys.
Yeah,
exactly. Long-term irreversible damage, kidney failure, God forbid, worst case scenario. So really important, please pee when you can.
Yes. I write notes for school children and people at work, like, this person needs to go. That is the doctor's order every 2 to 3 hours.
Good. I'm glad that and that's a very good perspective. Truck drivers drive long hours and sometimes have to hold it. Yeah. All right. So someone's watching who's like, well, all right, doc, I pee a little. What's the big deal? What would you say to someone who's saying that, well, I mean, I wear pads or I wear liners. I'm fine with it. What would you say to that person, as you know, who's wondering? I don't want to embarrass myself. It's embarrassing for me to talk about these things, and I'm glad you're having this talk and can ask questions, but I don't see the need to address this because it's not life threatening. What would you say to that person?
Well, there's a few different things there. I tell people, if you have leakage and it doesn't bother you, and it really doesn't bother you, it's not life threatening. You don't have to get it addressed. But if it is bothering you, there's no reason for you to deal with it. You can definitely go see a urologist, go see a urogynecologist. We have a lot of options. And we just have so many options. Many people think that all we have is medications and Kegels, but we have so much more than that. Those tend to be the first step. But if those don't work, we have interventions, we have combination therapies, we've got a lot of things we can do. So it's not too small an issue. If
Hmm.
it affects your quality of life, then you should get it addressed, because we all deserve to live our best lives here.
I
So, but if it's not bothering you, there's people who, yeah, I leak a little bit when I cough. It's not that big a deal. I wear a panty liner, and they don't want it addressed. They have no problem with it, and to them, I say that's good too. There's no reason to get an intervention if you don't really want one, and you also don't feel the need for it. So it very much is a quality of life, and it's individualized. And
Sure.
that's the beauty of what I do, is that so many times I'm dealing with conditions where the person gets to decide for themselves if they want to address it and how.
Fair. That's fair. I have another question.
Yeah.
So, for someone who's watching who says, well, what I've decided to do is not to drink a lot of water, so that way I don't have to pee as much. What would you say to that person?
I say that's never the right answer. No physician's gonna agree to become dehydrated. And it really, if you think about it, then your urine is more concentrated, probably a bit more irritating. And most of my patients who do this severe fluid restriction, they don't see much of a difference. They still continue to leak. And sure, they may leak higher volumes if they drink more, but the key is that they don't leak less because they restrict their fluids. So it's way better to just seek help, to go to bring it up with the physician, so that you can continue to drink and to remain healthy.
All right. Awesome. Water is very, 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 very important.
So important.
So you can't deprive yourself of that
Yeah.
because you come at an expense. So I have someone asking here, hi, Miss Shirley, do you have a preference of pessary for a sister seal? That's it. That's a loaded question. So start with the sister seal, what that is, and then a pessary, what that is, and how the two of them are connected.
Sure. So a cystocele is a type of pelvic organ prolapse. Pelvic organ prolapse, just in general, is when the organs of the pelvis starts to herniate essentially through the vagina, so through the vaginal walls. Most of the time, it's not life threatening. It's very, very common. And we treat it based on bother. So I tell my patients all the time, I could very much have a pelvic organ prolapse right now. And if it's not bad enough to the point where I can notice it, then I don't need to get it fixed. It's not bothering me.
Right.
So pelvic organ prolapse, it's a continuum, and the degree of bother depends on how bad the prolapse is, the state of the vaginal tissue. A lot of times that postmenopausal women who haven't done any hormone replacement therapy, any vaginal estrogen cream, they've got thinner tissue down there. They may feel it more. They may be a bit more sensitive and feel their prolapse when it's at an earlier stage. But essentially, prolapse tends to become bothersome once it gets to the point where it passes the hymenal ring. And so, many women have used tampons in the past. So I tell people, if you've put in a tampon before and you didn't put it in far enough and it irritated you, that's because you didn't put it in. It was a little bit was past the hymenal ring. So that's the area, the same location where if your prolapse gets to that far down, that's when you start to feel it. But when it's higher up, you won't feel it the same way you wouldn't feel a tampon. So That's pelvic organ prolapse in a nutshell. And then pessary is a form of treatment. It's one of our conservative treatments for pelvic organ prolapse. So the first mode of treatment is, you can watch it. It's like I said, it's not usually life threatening. So if it's not bothering you, you don't have to bother it. You are fine to have intercourse. You are fine to exercise. You don't have any special restrictions when you have prolapse. Now, if you are more active, the prolapse may worsen, but it can also worsen if you're not active. So the key is this is a quality of life thing. So you don't want to in any way decrease your quality of life to manage your prolapse. That's when, if you're feeling like you have to change your lifestyle because of your prolapse, then it's probably time for your prolapse to be addressed. But if you do want to address, but you don't want surgery, then we have vaginal inserts that we can fit you for, and those are called pessaries. There are a lot of different sizes, and in terms of like the best one, really what we do is we fit people for them. So we have a testing kit that tends to have 3 to 4 different types of pessaries. We will usually have some additional more uncommon ones if someone has a very significant prolapse. So the urogynecologist or gynecologist, urologist who's fitting you for it, or I think public for physical therapists are doing this now, family practitioners, but they'll fit you for it, usually with the one they feel the most comfortable with. Most of the time, it's a ring pessary. That's the most basic one. It's kind of circular, and we just put it in there, make sure it holds up your prolapse. You feel comfortable. You don't feel it when you're moving around. And that's how we fit for the pessary.
Okay, I hope that answers your question. That's a good question. Now, Doc, I have someone who's wondering. Okay, am I destined? Are you destined to have incontinence? Are there things I could do to make sure that that doesn't happen? What would you say to that?
Are you destined to have incontinence? No, not really. I mean, they've done surveys where, well into the 80 percentile, most women have an occasional episode of urge or urinary or stress incontinence. You laugh really hard, you leak a few drops. So, never ever having leakage is probably this one extreme. Bothersome leakage, definitely not destined to have it. Don't let anyone tell you that this is a normal part of aging and you just have it because you were going to have it. If you have incontinence and it's bothering you, go get it addressed. But you're not destined to it. In terms of ways to prevent it, just some of the things that I talked about that we do to address it, the behavioral modifications, you can do them preventatively. So don't start drinking a lot of caffeine. Don't develop that habit. Make sure that you're managing your bowels. So you're having a bowel movement every day, that you're not straining all the time and causing all this extra pressure on your sphincter, on your vaginal wall. So yeah, managing constipation. You want to make sure that you maintain your healthy weight. Increased abdominal pressure comes from weight gain. So we see that patients who lose weight, about 10%, we see a significant increase or decrease in their incontinence when they have stress incontinence. Women, once you've gone through menopause, a lot of folks are very scared of estrogen. Unfortunately, the FDA made us very scared of estrogen, this natural hormone that we make in our bodies. And after we go through menopause, men have more estrogen than we do. So preventing your vaginal tissues from getting weak. So starting hormone replacement therapy, either oral, vaginal, or in combination beforehand to keep your vaginal tissue healthy. These are things that we can do to decrease the chance of having bothersome incontinence.
Awesome. Very, very helpful. A wealth of information we've gotten this evening, Dr. Wilson. Thank you so much.
Very welcome.
Now I have someone who's watching who's like, I like this doctor. I like how, the way she answers questions. I would like to have her come here to talk to some of the women in my group who are a little shy about talking about these things because obviously is affecting their quality of life. They don't want to go out. They don't want to hang out. Doc, where can people find you?
Yeah, so you can find me at metroatlurology.com. That's my practice in Kennesaw, Georgia. We're accepting new patients, and I just opened my doors officially in October. So definitely ready to see anybody who is dealing with these issues. And And yeah, that's basically where you can find me.
All right, awesome. And what I'm going to do after this live, I'm going to have that information posted in the comment section so we can connect with you directly. But thank you so much for doing this on a Monday evening.
Definitely. Thank you for having me.
Awesome, awesome, awesome. And for you who are watching, thank you so much for joining us as well. Remember, caring is sharing. Be sure to share this, tag people who you think would find this very useful. And if you or anyone you know is looking for a thorough, a passionate, and caring family physician here in the Mansfield, Texas area, I am still she. You have a good one, okay? Thank you, Doc.
Bye, everyone.